Let's first define what is hypocalcemia. Normal total calcium level in blood is 2.2 to 2.6 millimole per liter or 8.5 to 10.5 milligram per deciliter. If total calcium in blood is less than 8.5 milligram per deciliter, then it is a case of hypocalcemia. What causes hypocalcemia? These are the causes listed: hypoalbuminemia, alkalosis, vitamin D deficiency, chronic renal failure, hypoparathyroidism, pseudohypocalcemia, acute pancreatitis, and hypomagnesemia. These are some of the most important causes of hypocalcemia, and among these, most common cause of hypocalcemia is decreased serum albumin, that is hypoalbuminemia. Before investigating to find out the cause of hypocalcemia, it is necessary to confirm whether there is true hypocalcemia or not. Why is there importance of confirming whether there is true hypocalcemia or not? It is not the total calcium that is needed for the functions of calcium like blood coagulation, muscle contraction or nerve conduction. It is the ionized calcium. So even when there is normal ionized calcium, sometimes total serum calcium can be less, but that does not show the symptoms of hypocalcemia. For example, in hypoalbuminemia, there is decreased serum albumin. That's why there is decreased total serum calcium, but ionized calcium is normal. So this is a case of pseudohypocalcemia. When we measure total serum calcium, it comes low, but there will not be symptoms of hypocalcemia because ionized calcium is normal in case of hypoalbuminemia. That's why calcium level should be corrected if albumin has decreased in the blood. The formula for calculating the corrected calcium is corrected calcium in milligram per deciliter is equal to serum total calcium in milligram per deciliter plus 0.8 into 4 minus patient's albumin in gram per deciliter. This 4 gram per deciliter, it is the normal value of albumin, and patient's albumin should also be measured in gram per deciliter. Even in hypoalbuminemia, even though serum total calcium is decreased, corrected calcium will come normal. These are the basic investigations required for finding out the cause of hypocalcemia: serum albumin, pH from arterial blood gas analysis, 25 hydroxy vitamin D level in the blood, parathyroid hormone level in the blood, total serum calcium, ionized serum calcium, and magnesium level in the blood. How they are deranged, how they are increased or decreased, in which cause, now we will see. How are the parameters total serum calcium, ionized serum calcium, serum phosphate, and serum parathyroid hormone affected in different causes of hypocalcemia? Let's compare hypoalbuminemia and alkalosis. First, hypoalbuminemia. In hypoalbuminemia, albumin decreases. Normally, albumin it binds calcium. Albumin is negatively charged, whereas ionized calcium is positively charged. So albumin, it attracts calcium ions and binds. But when albumin is less, then calcium cannot bind to albumin, so total calcium will decrease, but ionized calcium will remain constant. That's why in hypoalbuminemia, total serum calcium will decrease because of decreased albumin. Ionized serum calcium is constant, and it is the ionized serum calcium, not the total serum calcium, that has negative feedback effect on parathyroid hormone. So since ionized serum calcium is normal, parathyroid hormone will also be normal. So when serum parathyroid hormone is normal, then serum phosphate will also be constant. Let's now see alkalosis. Albumin is negatively charged. It binds positively charged ions like calcium ions and H plus ions, hydrogen ions. Hydrogen ion, it normally binds with negatively charged albumin, But in case of alkalosis, pH is high, it means hydrogen ions are less in amount. When hydrogen are less, they do not bind with albumin. That's why in place of hydrogen ion, more calcium ions, they bind with the albumin. Due to which, total serum calcium is constant because of no change in albumin level. But ionized calcium will be decreased because now ionized calcium they have bound to the albumin. That's why in alkalosis, total serum calcium is constant because of no change in albumin level. Ionized serum calcium is decreased because ionized calcium now binds albumin because of less H plus ions that are binding albumin. And serum phosphate, then since ionized serum calcium is less, it will have less negative feedback effect on parathyroid hormone, due to which parathyroid hormone will be normal or will be elevated. But elevated parathyroid hormone, it cannot change serum phosphate. Actually, parathyroid hormone must be able to decrease serum phosphate, but it is not so high that serum phosphate will be decreased. So the difference between these causes is, in hypoalbuminemia, total serum calcium is decreased but ionized serum calcium is constant. But in alkalosis, total serum calcium is constant but ionized calcium is decreased. And due to the effect of ionized serum calcium on parathyroid hormone will be normal in case of hypoalbuminemia because of constant ionized serum calcium, but in case of alkalosis, it will be normal or will be elevated. Now let's compare vitamin D deficiency and chronic renal failure. In vitamin D deficiency, absorption of calcium and phosphate cannot take place through intestine, as well as reabsorption of calcium and reabsorption of phosphate cannot take place through kidneys. And resorption of bone also does not take place due to lack of vitamin D. Due to this effect, total serum calcium, ionized serum calcium and serum phosphate, all three decrease. Because of decreased ionized serum calcium, because of negative feedback effect on parathyroid hormone, serum parathyroid hormone will increase. Because decreased ionized serum calcium will stimulate the parathyroid gland to secrete more PTH. In chronic renal failure, there is diseased kidney. This diseased kidney cannot reabsorb calcium and cannot excrete phosphate, due to which total serum calcium and ionized serum calcium decrease, but serum phosphate will increase. Due to decreased ionized serum calcium, because of negative feedback effect on parathyroid hormone, again similar to vitamin D deficiency, there will be increased serum parathyroid hormone. So which parameter is different in these two cases is serum phosphate. In vitamin D deficiency, serum phosphate will decrease, whereas in chronic renal failure, serum phosphate will increase. Now let's compare hypoparathyroidism and pseudohypocalcemia. The most common cause of hypoparathyroidism is the removal of parathyroid glands during thyroid surgery. And what is this pseudohypoparathyroidism? Pseudohypoparathyroidism means there are the symptoms of hypoparathyroidism, but serum parathyroid hormone is elevated abnormally. It is like parathyroid hormone resistance. Parathyroid hormone, it binds to parathyroid hormone receptor, and then it is coupled with the G proteins, and G protein will increase CAMP, and like this it functions. But so in pseudohypoparathyroidism, parathyroid hormone binds to normal receptor. PTH receptor is normal, but the downstream signaling pathway are defective. There is the gene GNAS1 that synthesizes alpha subunit of stimulatory G protein is inactivated here, due to which alpha subunit of GS protein cannot be synthesized and downstream signaling pathway will not work. There is parathyroid hormone, but it cannot activate the downstream signaling pathways. So it is like parathyroid hormone resistance. In hypoparathyroidism, the problem begins from parathyroid gland. That's why serum parathyroid hormone will decrease. The function of parathyroid hormone is to increase serum calcium and decrease serum phosphate by acting on bone, kidney and intestine. So reverse will happen. That is, total serum calcium and ionized serum calcium will decrease and serum phosphate will increase. In pseudohypoparathyroidism, because of parathyroid hormone resistance, there is elevated parathyroid hormone, but it cannot activate the receptor to cause its functions, to cause its actions. That's why the parameters, total serum calcium, ionized serum calcium, serum phosphate, they will be similar to hypoparathyroidism. Difference between these two causes is just in serum parathyroid hormone, which is decreased in hypoparathyroidism and increased in pseudohypoparathyroidism. Acute pancreatitis and hypomagnesemia are also the causes of hypocalcemia. In acute pancreatitis, there is release of pancreatic enzymes. Among those enzymes is lipase. This enzyme degrades fats into free fatty acids. These free fatty acids, they combine with calcium to form soaps, which process is called saponification. Due to the combination of free fatty acids with calcium, total serum calcium and ionized serum calcium both will decrease. Decreased ionized serum calcium will stimulate parathyroid gland to produce more parathyroid hormone. This increased parathyroid hormone will try to normalize or decrease serum phosphate. Magnesium ion is an important ion which is required for the secretion of parathyroid hormone by parathyroid gland, as well as it is required for the action of parathyroid hormone on bone and kidney. If there is magnesium depletion in blood, then parathyroid hormone secretion will decrease from the gland, as well as actions of parathyroid hormone on bone and kidney will decrease. Because of this reason, first, serum parathyroid hormone will decrease. Because of decreased parathyroid hormone, serum calcium will decrease, and serum phosphate is variable. It can be normal or it can be increased. How do the patients of hypocalcemia present clinically? If there is mild hypocalcemia, then mostly they are asymptomatic. In children, tetany occurs. Tetany occurs because of increased neuromuscular irritability. So why is there increased neuromuscular irritability in hypocalcemia? Calcium of extracellular fluid, it stabilizes sodium influx. It does not allow sodium influx to occur and to cause spontaneous depolarization. But when calcium is decreased, increased sodium influx will occur, because of which there will be spontaneous depolarization, and because of this spontaneous depolarization, there is increased neuromuscular irritability. In children, triad of carpopedal spasm, stridor and convulsions occur. Carpopedal spasm means flexion of metacarpophalangeal joints and fingers and adduction of thumb. Stridor is because of spasm of glottis, and convulsions, that is seizures. But in adults, stridor and convulsions, they do not appear, but there appear paraesthesias in association with carpopedal spasm. Paraesthesia means tingling sensation in hands and feet and around the mouth regions. In case of vitamin D deficiency, both calcium and phosphate decrease, because of which there can be rickets in children and osteomalacia in adults. In hypoparathyroidism, serum calcium is decreased, but there is hyperphosphatemia, because of which there is calcification of basal ganglia. There will be grand mal epilepsy, that is seizures. There will be psychosis and cataracts. To detect latent tetany, that is tetany which has not appeared clinically, there are two signs, Trocheus signs and Vostek sign. In Trocheus sign, inflation of sphygmomanometer cuff is done just above systolic blood pressure, and this causes carpopedal spasm within 3 minutes of inflation of this cuff. This is called Trocheus sign. In Vostek sign, when facial nerve branches, they emerge from the parotid gland. When these branches of facial nerve, they are tapped, then there will be twitching of facial muscles, especially around the mouth regions. This is called Vostek sign. In ECG, because of hypocalcemia, QT interval increases, This can give rise to torsades de pointes and ventricular arrhythmias. Whereas in hypercalcemia, QT interval it shortens.